It's 10:08 at WPSL 1590, the talk of the Treasure Coast. And you are on Bone Talk with Dr. Joe Wiersbecki. Good morning, doctor.
Hey, good morning, Greg. How are you?
Doing fine. How are you?
Excellent, excellent. Nice day here. The sun is out, middle week. Actually, now it's late week. Yeah, we're doing all right. We're almost there to the weekend, so I'm doing great.
Yeah, well, let's see. Oh my goodness, what have we got here? Holy smokes, we may have a cast of thousands.
I thought you were going to say the phone lines are blowing up, all kinds of callers coming in. Oh, but we got Dr. Southern connecting in too, I see. Great.
Yeah.
For those people listening to us, we're doing Bone Talk every Thursday now. We're on that 10 o'clock to 11 o'clock time. And so, I'm coming to you live from Florida Orthopedic Specialists. Our number for Florida Orthopedic Specialists, if you want to see us in our clinic, is 335-4770, 335-4770. If you want to see me in this office in Port St. Lucie or in our office in Stewart, which is right next to Willoughby Golf Course. Oh, and Dr. Southern's logging in right now. Yeah, he'll be with us soon. And of course, if you want to give us a call live on the air, the number is 340-1590, 340-1590 if you want to call us on Bone Talk this morning. We'll take the orthopedic questions. We'll take general medicine questions. We'll take sports questions.
Yeah, there you go. Well, of course, we had to get Dr. Southern off the pitch and putt, which is something new off in back of your Stewart office, right?
Oh, there he is. Hey, morning, Dr. Southern.
Computer headaches down here. How is everybody?
Very good, thanks.
Computer headaches.
Amazing.
Well, join the entire world, my friend.
Every day is a new day. So
as these years go by, it seems like our computers keep getting better, but we have just as many problems, if not more problems, with the computer and technology, which is something that blows my mind. Windows still crashing. Computer systems not functioning right. USB, Bluetooth not working right. I don't get this. How is our technology getting so good that problems keep happening? I don't get it. So whatever.
Well, it's all going to be better when we go to windmills.
Like in medicine, they're making us use more technology now. Like it is a rule that a medical clinic, for the most part, it's something like 95% of your prescriptions have to be sent through the computer and through the electronic medical record. There are certain things that by law and by Medicare and Blue Cross Blue Shield, we have to do by technology. So they're forcing us to use this technology. And now the technology is what is failing us. Dr. Southern would probably agree with me. In medicine, we have become not as much doctors. We've become computer programmers and, we've become lawyers and trying to understand the law and Medicare rules. We've become paper pushers. The medicine is the easy part, but we barely do that now. We're having to learn and do all this other stuff. That's what really helps our patients. So it's funny.
Okay, I've got a dumb question. If they're pushing all of this electronic stuff and you have to do that, what happens when you have a hurricane or a tornado and you don't have the luxury of internet? Do you just go back to paper then at that point?
Oh yeah, there's fallback plans. I mean, it happens in the hospitals all the time. If they have the system crashes and so forth, there's always a paper chart, backup plan, and so forth. To Dr. Wiersbecki's point, that the whole frustrating issue with the electronic thing, it was in theory supposed to make it so medicine can communicate not even nationally but globally. Mm-hmm. And anybody who's a current, retired, active veteran, or whatever the case may be, knows that the VA computer system is probably one of the most disastrous computer systems out there. It's supposed to be it is a federal system that communicates. You can pull up your chart at any VA hospital in any part of the country. And it's a train wreck. And now we have all these different systems, all these different communications. No one, they all don't speak to one another. There's no centralized database. And it's actually quite unfortunate because the lay population is under that false impression. It's whether they don't want to learn or they're being miseducated or they're not being advised, whatever the case may be. I don't know about you, Dr. Worsbecky. I see countless patients throughout the day, like, oh, you didn't receive that, or they didn't send it to you. They were, I was there. Don't you have access to such and such? And it's just, I'm
Exactly.
sorry, but that's just not how it works.
Yep, that's the issue I see all the time. Patients assume that I have access to the VA medical system, to Cleveland Clinic's medical system, to the radiology spot down the street. But you're right, none of these things communicate with each other. And that's kind of been the great tragedy, or the great kind of bad thing that has happened, is that they've allowed this to happen, legally or whatever, where you have all of these independent systems that don't work together. It's kind of like, your iHome technology, with your Alexas and your Googles and your Siris. They each have their own individual product, but they don't work together. Now sometimes they do work together, but it's by far worse in medicine. None of these things communicate. And it makes our job more difficult in trying to log into multiple medical systems. And it makes your job difficult trying to get that stuff to us. It's a big disaster. And that's one of the big problems with our medical system, is how they've allowed this, but it is what it is.
Yeah, well, we ran into that in television back before both of you were born. And that was when we went to tape. And there, all of a sudden, Sony came up with this whiz bang new thing called Beta. And then VHS came up with its own thing. And so all of a sudden, you had some television stations using one, the others using the other, and it was a mess for several decades. Of course, it's all digital now. So, but
And so when
still.
it comes to medicine, I mean, you can't even trust these systems, because sometimes someone will be in our office saying, okay, we need this important, maybe lumbar spine operative note from your surgeon. Okay, let's just get on the phone and have them send that over. But we are such low priority on these other people's list, for Cleveland Clinic to send that over, or whoever, that it'll come weeks, months later than we asked for it, if ever. And so that's why I'm often telling patients, you need your own medical record. You need your own hard copy in a binder. Something happens, you have to go to the hospital, you're on vacation, or you're just in your hometown. Bring that with you. You need this past medical information for your doctors. You need an accurate medication list, because it's unfortunate, but it's true. You can't trust the computers, and you can't trust these other employees and organizations to help you out in your time of need. So you have to have these backups with you.
Well, and it was very interesting because, my GP, his practice was purchased by Cleveland. So anyway, long story short, he filled out stuff to go to my lab. And of course, the upshot of that was the lab never got his paperwork. And the rationale then from the office people at the doctor's office, which were Cleveland Clinic types, well, you just need to go to Cleveland Clinic rather than the other lab. And I said, wait a minute, this is crazy. Yeah, it's amazing the world we're in. There's just no doubt about it. So anything new in your biz at all?
Dr. Southard, you mentioned the other day about that shoulder procedure, and I thought I just saw a highlighted email study sent my way. You were talking about how people with chronic rotator cuff tears, how there's people investigating putting a balloon in there in order to give that cushion and that mechanical push that the rotator cuff isn't there to do, and how it's sometimes a nice little Band-Aid for people. Have you seen some of these updated studies and I saw this headline that says that maybe that procedure doesn't work as well? Was this a bad headline, or was this clickbait that I didn't click on?
I'm not sure what the email you're referring to, but there have been promising results with that procedure. What Dr. Worsbecky is referring to is something called a balloon arthroplasty, and it's one of the things in orthopedics, in particular in shoulder, that we still don't have the great solution to. When you have soft tissue loss, rotator cuff loss, and then I'll even back up a little further. We still don't even fully understand the rotator cuff. I mean, why? There's three of us sitting here having a conversation. All three of us could have the identical injury. same amount of tissue loss, same amount of muscle degeneration. Take out other, and we're all male. Let's just take out the other factors that there's a little bit of age differential here. But, for conversation purposes, let's make us all within 5 or 10 years old of each other. Each of us could have a completely different clinical complaint, functional use of the arm. And why is that? And we still to this day don't have an explanation for it. But in those patients that have supraspinatus in particular, tissue loss, dysfunctional rotator cuff, lack of function, clinical complaint, there's still no good solution how to fix that. We've tried things like superior capsular reconstruction, which is basically putting a convertible top over where the supraspinatus used to be to try to keep the humeral head at bay and from escaping out of the top. I've been telling my patients lately, and it's been working for me insofar as an analogy. When you look at the rotator cuff, you look at the supraspinatus complex as it literally is the top of your convertible, right? You're driving around the top of you're driving around your convertible on a bumpy road. If you have the convertible top up, you don't go flying out of the car. You might bang your head on the roof a couple of times, but you're not going to wind up in the street. If your convertible top is down, it's not going to happen. But in theory, you hit a big bump, you could fly right through the top. And that's what happens with superior escape in supraspinatus or rotator cuff deficient patients. That moment arm, when you're lifting up your arm and your deltoid muscle is pulling, the humeral head slides up the face of the glenoid and wants to come out the top because the soft tissue restraints aren't keeping it there. So what have we tried? We've tried things like superior capsular reconstruction. We've tried things like allograft, putting in supraspinatus tendon, Achilles tendon, and the varying results are all over the place. And there's a lot of long-term studies coming out now. In particular, one that just came out in the journal Shoulder Elbow is the long-term sequelae of a superior capsular reconstruction actually leads to less ideal results in patients that ultimately have to go on to get a reverse total shoulder. So this balloon arthroplasty is another attempt to put some type of block from the humeral head coming out the top. So if you think about it, it's a big air mattress, right? It's filled with fluid, it's not air. But think about it, you put a big air mattress in the patient's shoulder in the subacromial space, fill it up with fluid, and the theory is that's supposed to bathe the top of the humeral head, the subacromial space. And as you lift up your arm, your deltoid muscle lifts up your arm in forward flexion or abduction in particular. It blocks the arm from coming out the top, and you're able to move your arm. Now, the patients you're having the most results with, the best results with, are the ones that have what we call an intact force coupling mechanism. So as you generate the force of the arm coming up, it stays in place, so to speak, and the other muscles can allow it to come up in space. But if you lose that length tension force coupling mechanism, the balloon is less effective.
That's cool. I could have a helium shoulder.
Yeah, well, saline, but yes.
Saline.
But it's for patients that are of advanced age. They're not ready for whatever reason for arthroplasty, but they're not candidates for a rotator cuff reconstruction, but they really have a dysfunctional complaint.
So Dr. Southard, we've talked a lot about, and patients hear this all the time, you never want to have to repair a person's rotator cuff. And so as I'm thinking about this and trying to explain it to different patients, I think back to in our ankles, we talk about this a lot. A person will sprain their ankle. They will tear multiple ligaments in their ankles, and we'll tell them, it's okay. This is something extra. You don't want this surgery. The surgery is unnecessary, and you'll only need it in a very rare case when you fail physical therapy, fail conservative management, that you may need these ligaments repaired. And people do great with these ankle sprains and understanding that concept that this is something extra that we can rehab through and your body can live without. And so I guess and maybe you see where I'm going here and how I'm trying to connect this to shoulders. But I mean, really, there are very few, correct me if I'm wrong, but there are very few people who should actually have a rotator cuff repair Your overhead athletes, your $1 million sports pitchers, people who fail conservative management. So am I looking at this in kind of the right way? And maybe we need to be discouraging the large majority of people from getting a rotator cuff surgery in the first place? Or what do you think of what I'm saying here?
It's all age dependent, functionality dependent. To your point, not to be overly, precise, the difference between ligaments and tendons, so to speak. So when you're talking about those injuries in the ankle, those are ligamentous structures connecting bone to bone. Tendons are a totally different story, muscle to bone. Tendons are more they're usually indicative of some type of functional deficit. You can have, the sprained ankle you're talking about. So let's say lateral ankle sprain, the most common ankle sprain where you roll to the outside of your ankle. Some people even feel that little bump, that lateral malleolus will contact the ground because they have this quote unquote inversion mechanism. You could have a grade 1, 2, or 3 sprain. Even your grade 3 sprains, which is the most severe with a complete ligamentous tear, most patients tend to do well. Now, your higher demand athletes, your younger patients, your so forth, those patients, should see a foot and ankle specialist. They may get a tendinous reconstruction acutely, but not your grade 1 and 2s. The rotator cuff is a little different, right? If you have a young, healthy, functional patient, intact force coupling mechanism, no glenohumeral arthritis changes or so forth, and they have a true functional limiting tear, that should be fixed because they will get worse. Go ahead.
So if you had someone who's young-ish, in their upper 20s, playing with their son and they fall off the monkey bars with them, and he's an office worker, are you really rushing to repair that guy's rotator cuff? Or what are your thoughts on someone who is young-ish and maybe doesn't have the demands on the rotator cuff throughout his life? But sorry for interrupting you there.
Yeah, no problem. So it's a loaded question. Now, the interesting thing with shoulder, and I would think most of the audience, and I actually did a talk locally at one of the community centers up in St. Lucie. Most people don't walk into the doctor's office within a few days or a week of having a shoulder injury. Like the same thing with your back pain.
Yeah.
How many times?
More likely
3 weeks,
2 months.
3 months, 6 months. You know what I mean? It's just, it's one of the, and especially as we get older in age. Now, I hate the stereotype. Our younger generation, they're not built like Greg's generation. I mean, and even the people that are senior to Greg.
It's kind of like comparing Michael Jordan's generation of NBA, to LeBron James's generation here. Yeah, it's different. I mean, let's just all accept it. Yeah, it's different.
Oh yeah. Put Bill Laimbeer on the court with some of the current NBA players, and or put Isaiah Thomas on today's court. He would run through people like, hey, he's a Mack truck. Yep. It's
exactly.
Just a different generation of person.
So hey, by the way, that I want to bring up there was a post on Facebook, the number of times that a scored 50 games or more, or 50 points a game, and Wilt Chamberlain had 118 games, and you could go Michael Jordan, Kobe, and all the rest of it. The other 4 didn't even come within 20 games of Wilt Chamberlain.
Yeah, but you're biasing yourself, because if you look at all the pictures of Wilt Chamberlain when he was playing, he was 3 feet taller than everybody else on the court.
Now that's true. That's true.
So, because he was so dominant. I mean, they had 2 or 3 different rules of the NBA specifically because of him, and he was so dominant. Yeah, Wilt.
That's right.
I mean, the man's a stud. Don't get me wrong. Kudos to him, but he would not have as many 100-point games if you had Horace Grant, Bill Laimbeer, and Shaquille O'Neal all defending him. You know what I mean?
Fair. Yep.
Oh, that's fair. That's definitely fair. Yeah.
But anyway, so getting back to the rotator cuff, if you have a full thickness tear, and a young patient, it should be fixed, because they're going to get worse. It's nice. They come in, they may be one of those people that don't truly have functional deficits. They're not fully complaining on something, but we know in our literature that a full thickness rotator cuff tear is going to get worse. The question is, at what point do you become less aggressive with full thickness tears?
Yes.
And I've had this conversation with one of my colleagues over in Sarasota, who also trained and did his fellowship where I did. He's probably a good 10 or 15 years senior to me in his practice. And, as a new guy coming out, I was having a dilemma with, who to treat, who not to treat. We talked about this, a couple of times on this show. The 65 to 70-year-old population in Florida, especially coastal Florida, is very different than the 65, 70-year-old patient in a less, destination type, resort type, retirement driven community where people are coming down here for the sole purposes of being active year round. And our patient population is a little bit more demanding. I mean, I know that's an overgeneralization and stereotype because I don't live in, say, northern Minnesota, or I don't live in Nebraska or so forth. I guarantee you there's athletic people that want to be functional in those areas too. So we may be a little biased, but in our particular practice and in my particular practice, I see it more here than I did when I was in New York. My older patients want to be 30 again, or they want to be a functional 68. They want to play their pickleball. They want to play their golf. They want to go on trips. They want, you know what I mean? So a full thickness rotator cuff to a 68-year-old avid golfer is a problem. A full thickness rotator cuff tear to a 68, 70-year-old patient who all they need to do is pick up their remote control and grab the beer, that's not a big problem.
Kind of like me. Jerry's on the line with you guys. And Jerry, good morning.
Good morning, Greg. Thank you for taking my questions, Doctor. I was just wondering, a while back, I asked a question about boxing, and I wondered in Fighter's Corner, I had a stroke about a year ago, but they have what they call a cut man, and when the fighter can no longer see her, does he do something with a razor blade, a cut man? I was wondering what they call the fight off if a fighter can no longer see. And I'd like to listen off all doctors, if that's okay.
Yeah, excellent question.
A cut man, boy, yeah, that goes back to some of my Hagler Hearn days. Yeah.
Obviously, you got to stop bleeding, as soon as you can. Stopping bleeding helps to control swelling. You of course want to minimize blood loss, and so especially cuts around the eyes. You think a fighter has to be able to protect himself and see properly. Otherwise, he's in a much greater risk of danger and severe hits that he can't see and protect himself from. And so especially if someone has too much compromise of their vision, the blood is pouring too aggressively into the eye, there's too much swelling, or maybe there's concern that maybe their vision is actually compromised because the swelling is impacting on the nerve or the eye's ability to move and protect itself, then the fight has to be called off in those scenarios. And so I guess in a generalized way, the cut man's job is to try and control swelling and bleeding so that it doesn't lead to vision compromise. Dr. Southern, you may be aware of too, what are they actually using, on the ring side in order to control it? Are they using like a silver nitrate chemical? Or are they using like a clotting agent that like the military would use, or is it just pressure? Any idea?
I'm not sure. I mean, that's an interesting question because it's funny because when you hear about the cut man, we all think about the one where the guy cuts the eyelid so it droops down. The patient, and that used to happen back in the day, right? And I'm not a boxer.
I didn't even think
but
about
if your eye is so swollen that you can't lift up your eyelid, there was a time, and I don't know if it still happens now, where a thin razor blade, you cut the eyelid and the lid would go, and there your eyes open again.
Yeah,
that's where the term cut man came from. It wasn't because you were treating cuts; it was because you were doing other things. But yeah, I mean, you see them on the sideline; they go immediately for the ice pack. And I wish we had someone on air that was a former boxer or a cut man or what have you. It almost looks like they use a Vaseline type substance, something obstructive or so forth. Because you see the big goo across the face and whatnot. But to your point, getting back to it, especially in today's modern age, it's become safety, and more safety. Mm-hmm. It's protect, number one, paramount, protect the fighter. Number two, protect the other fighter, the ref, and the spectators. I mean, growing up when I was a kid, even refs didn't wear gloves. Now refs wear gloves they wear disposable gloves. And I'm talking pre-COVID. Now everybody wears gloves and masks outside by themselves and so forth. But pre-COVID, people were weren't wearing gloves. I mean, there were a time that police officers didn't have gloves in their back of their car. Now there's a box of surgical gloves in most police officers' cars, most first responders' cars, who are not EMT paramedics. And I mean, look, case in point, we're talking about basketball before. If someone has an open cut on the basketball floor, game has to get stopped. That player has to come off. They need to have that wrap. The blood has to be wiped from the floor before the game can go on. Wrestling, same thing. I mean, FHSAA has very specific rules that if there's an open wound and there's blood exposed, that player has to come off the field until the blood has been bleeding has either been stopped and or covered. So, but yeah, that's a unique field because they just do some amazing things. They stop bleeding pretty instantaneously. Maybe they pack it, maybe they cauterize, and it's possible for, say, a bloody nose or whatnot. They do some cauterizing agents in there. I wouldn't be surprised if they were using some type of vasoconstrictor, not necessarily a cocaine substance, but that is the key, the key vasoconstrictor. In fact, we use it in the OR, in the ER. If you come in with an intractable bloody nose, we still have a cocaine liquid that you can put on nasal packing and put into the nose. Now, you're not going to put nasal packing in the nose of a professional fighter because they'll probably become hypoxic very, very quickly and not be able to function. But yeah, it's something I'd have to look up though. But they definitely have tricks that you and I don't have in our back pocket.
Yeah, I remember covering this young kid who became a pretty famous boxer, Oscar de la Hoya, and his daddy was his trainer and his cut man. And yeah, they used to have this huge tub of Vaseline in the corner. Now, whether it was the same Vaseline you could walk into and get at a store, I don't know, but it was one of those containers that they used. Yeah. Good question.
Military training. Do you guys have to go through some of those like field, EMS, ACLS, emergency scenarios? And is there anything cool that the military, packs you guys with as far as some of those, clotting agents where if someone has an abdominal wound and you guys are in the middle of nowhere where you're pouring that stuff to clot? Have you come across any of that cool military stuff?
I personally haven't because, I'm a late guy. I came into the reserves a little bit later. I didn't do a lot of, on-field medical training. But we have some critical care nurses that go on the flights. They are exceptional people insofar as their ability to handle battlefront training. There was actually, not getting overly specific, there was one course that I wanted to go to that my unit was taking care of recently, where learning how to take care of injured members in the middle of a battlefield. So what they would do is they would bring docs, nurses, EMTs, to a course, and the instructors would be on the sideline with paintball guns, and there would be basically a war going on, and you'd have to teach them how to do extrication, immediate medical care, hemorrhage control, extrication. So I definitely would love to go because I couldn't get the time off. We had too many things going on. But it's like these are real world scenarios, right? Like, how do you get somebody that's in the middle of the field bleeding? And it's not the field like the Civil War or whatever that movie was that Mel Gibson was in years ago. I forget the name of that movie. Oh, The Patriot. It's not quite like that anymore. A lot of things are done more, obviously with stealth fighters and distance-based war, so to speak. There's not too many front lines where I'm looking at my enemy and shooting at him and then stabbing him with a bayonet if I miss. Those days are over. But you do get people that get injured in the front. That's where the medevac copters come in. So, you might have a small unit deployed for X amount of, for some type of mission. That person gets hurt in the middle of a gunfight. The medevac has to come in and extricate. Now, usually it's the folks on scene that do the initial extrication. They try to get them out of harm's way to get them to the medevac. But who's to say that as you're retreating to the chopper, the person that's shooting at you is just going to stop shooting at you, and that they're not. So, but yeah, no, they have some cool stuff. Absolutely. And that's actually where a lot of our science are. A lot of our people don't understand, and I don't want to say that we experimented on soldiers and midshipmen and airmen, in the various branches and corpsmen, but it's a lot of what we see in medicine today, especially in trauma. The trauma research, orthopedic, general surgery, has come from what we learned from on the battlefield. and we've just mastered it in the civilian section. And then of course it goes back to them.
And the same thing too, some of those military studies, and research when it comes to medicine or whatever, is all that much more useful to us because more control. You try and study the general population and you're looking at the effect of a blood pressure pill chronically, or in a training regimen in the general population, you're not able to control for factors such as, where they're living at, their diet, what kind of training regimen. While in the military, everything is much more controlled. It's so there's a number of factors that you don't have to consider that could be messing up your results. And so I've seen some of the best studies come out of the military for orthopedics and medical.
Yeah, I
There's
remember.
no such thing as lost the follow-up in the military.
Yeah,
Exactly. Lost the follow-up, big one too.
yeah. Well, and it was very interesting going the other way, if you will, remembering back to the 80s and where the military brought in a bunch of doctors into Martin Luther King Hospital in Watts to train them for battlefield because of 40 or 50 gunshot wounds every weekend in South Central. I mean, that was amazing training for them.
Yeah, no, I can imagine. I could tell you some of the best physicians that I've worked with, at least from a hands-on exposure, have been previous servicemen of some sort. One of my faculty mentors in my shoulder elbow fellowship, Mark Mile, he was a Navy serviceman for X amount of years. Another famous, he's still active, another famous shoulder guy, Matt Provencher, out at Stedman Clinic in Colorado. I mean, these guys were active duty military doing general orthopedics, trauma, sports, so forth. And I mean, they were the first line, the last line. I mean, you just, it's on the job training. You learn on the fly. I mean, you're obviously fully trained from a residency standpoint, but the pathology that you see, especially at wartime, you can't duplicate that in any setting whatsoever. You just can't.
Yeah, that's amazing. That is
340-1590 if you want to give us a call live on air, 340-1590. And of course, if you want to see me, Dr. Wiersbecki, or my partner here, Dr. Southard in clinic, our number for Florida orthopedic specialists is 335-4770, 335-4770. And Dr. Southard, we were talking a little bit about the rotator cuff, and kind of getting back to that, you were telling me something interesting the other day that I hadn't thought of before and hadn't been told before. So I always thought when you're doing these arthroscopies, the scope where you're just kind of looking in, that there was so much room and you're able to kind of look around with that scope so easily, because I was thinking of something like a knee, where there's extra space and you can take your time and look around. And you were telling me about some of the complexity and the art to doing the shoulder scope, where some of these tissues are really pressed together and you're having to use pressure to separate them so that you can get a good look, and then how that continued high pressure can affect the tissue and can affect how well you're able to do that scope. And so it's really more of an art than I originally understood. And so I was hoping you could expand on that for the general population to understand just how complex a shoulder scope is.
Yeah, I mean, any arthroscopy, any scope, whether it be laparoscopy, in the abdominal cavity in general surgery, arthroscopy, in the joint in orthopedics, uroscopy, GYN / urology, doing things, in the low pelvis. It's first thing you need to do is visualization, right? And the way that we get in visualization is using a medium that you can see through, fluid. So we use a neutral fluid that is not what we call hypertonic or hypotonic. It's the same density, same amount of salinity as, say, the body fluids. So it doesn't overabsorb or underabsorb. And it has to be pumped into the area that you're working on. So in orthopedics, it has to be pumped into the joint. Now, when you're doing a knee arthroscopy, you tend to have a defined capsule. so a soft tissue balloon or bag, so to speak, around the joint. The fluid doesn't regularly escape as easily, and you can do it under much more low pressure, and you have a little bit more time, in the knee. Now, if you're doing complex knee reconstructive procedures, posterior lateral corner, so on and so forth, a lot of those are arthroscopy based / open. But your longer procedures in the knee, for example, like an ACL reconstruction, PCL reconstruction, anything that you're doing inside the joint, the knee is a significantly more forgiving joint than the shoulder. In the shoulder, yes, there is a capsule around the shoulder, but there's also areas in that capsule that, by definition, if you're doing a repair on something, is disrupted. So if you have a rotator cuff tear, there's a hole communicating from the inside of the joint to the outside of the joint. So as you insufflate fluid into the joint, that fluid escapes. The other thing with the rotator cuff, or the shoulder in particular, a lot of your work has to be done both intra-articularly and extra-articularly. So we go into if I'm going to do a standard run-of-the-mill supraspinatus repair, single tendon, double row repair, so that's 2 anchors closer to the articular surface, and usually bringing that out to 1 anchor laterally. But you get a nice mattress stitch and so forth. I have to do work inside the joint to make sure that I release things, open up the space, open up the capsular space, so on and so forth, make sure the patient has the right amount of mobility in the shoulder. There's no other lesion in there. I also have to look up top, make sure that this patient doesn't have, AC joint arthritis, subacromial decompression necessary. Is there an impingement type picture that's causing the rotator cuff tear? Do I need to create more space? And then, of course, now you're up top working from the outside in to grab the tendon and bring it over and so forth. And it's that in particular, when you come outside of the joint and you're insufflating fluid essentially to the underbelly of the deltoid muscle, the fluid gets absorbed. So that's where shoulder arthroscopy is far more challenging, because even under a low flow state, that fluid gets absorbed into the soft tissues, and you can see it. Anybody, medical student, nurse, so forth, that's observed a shoulder surgery, you watch the shoulder blow up like a balloon after a certain amount of period of time. You really do have a limited amount of time before you have to finish and or convert to an open procedure.
So what happens if you give too much pressure? What happens if the surgeon were to spend too long, with that higher pressure, with that extra fluid? Does it hurt the rotator cuff? Does it hurt your deltoid? Does it give people a lot of post-operative pain if they're exposed to too much of this? What happens?
I mean, the worst extreme is patients can get fluid extravasation into the soft tissues and into the vasculature, potentially throw things like air emboli and so forth. That's the worst case scenario. That's very rare at best. You're talking about, guys that are doing, men and women that are doing scopes for 3, 4, 5, 6 hours at a time, liters and liters of fluid. That just doesn't happen, right? But more so with the fluid issue is you lose visualization. So high flow is actually your enemy, low flow is your friend. So if I push fluid in with more pressure.
So why I understand the pressure, but why would you have a low flow versus? I'm not understanding the flow part of it. What do you mean?
It's the rate of which that you push the volume into the shoulder. So if you push the high, if you put a lot of volume into the shoulder very, very fast, that also increases the pressure in the shoulder. Whereas if you insufflate fluid at a much lower rate, the pressure that is going across the joint surfaces is much less decreased, right? So you're not forcing the fluid into the shoulder or the knee or the belly or at such a rapid place. I mean, a perfect example is hysteroscopy. So your OBGYN surgical specialists that do things like hysteroscopy that have to go inside the female's uterus. They actually use a different substance called glycerin. It's not actually saline. So they have a very limited amount of time. The uterus is very vasculature. There's a lot of blood vessels in there for obvious reasons. It's a nurturing chamber for birth, right? So, but the substance that they use can get absorbed into that tissue very, very quickly. So they have to do low flow, fast procedures, and there's a limit to how much volume that they can put into, that the body can tolerate in the uterus, because it gets absorbed. Now in the shoulder or in the knee, it's kind of the same thing, because as the soft tissues start to swell, they swell from the inside out, but then they start pushing back on themselves. So the whole idea, if you think about it, the shoulder proper itself, the actual proximal humerus and the rotator cuff tissue that is around the proximal humerus is sitting in space. So if anybody that's looked at or can Google a shoulder X-ray right now, you'll see what we're talking about. You look at the shoulder joint proper, and then there's a bone on the top of it, which is the acromion, where the clavicle comes into space. But there's space there. You see there's a black space or whitish gray space, depending on how clear that X-ray is. And that's your subacromial space. That's your working distance. You put the fluid in there, it's number 8, so you can see, so you're not looking at blood, you're not looking at other things. It also creates a lens effect, which it helps magnify what you're looking at, and expands the joint to give you a little bit more working room. Now, as you insufflate more fluid, that fluid gets absorbed into the soft tissues. The soft tissues are fine for X amount of period of time, but then once you crest that threshold where they start to swell, now they start to push back. So now you're swelling, you're fine, you're fine. You start to get a little swelling, you start to get a little swelling, you start to get a little swelling.
You can see
now you've swollen to the point where you're too swollen, and now the tissues start to push back because they start to swell more. So now it's a self-defeating prophecy where there's so much fluid being absorbed into, say, the adultoid tissues or the third space tissues, so forth, the interstitial tissue, which is another word for connective tissue in between certain, various body parts. Now it starts to push back. So in theory, instead of insufflating the joint, you're now insufflating the soft tissue, and the balloon is blowing up bigger and bigger, and now your space starts to collapse, and then you can't see. And once you can't see and you can't mobilize your instruments, now you're in a tough spot.
How long does a normal scope take of a shoulder?
Your standard scope to just kind of clean out, bone spurs, or versus, and then maybe add in, how long does your standard, just simple rotator cuff, run-of-the-mill rotator cuff repair take?
I mean, that's a loaded question, because I don't know what I'm allowed to say on air, but
hour?
No, I had an analogy a guy analogy about measurements and stuff like that, which we're not going to use on air.
No.
Every surgeon likes to brag, that they're the fastest. I don't think that we're in a profession that should be measured by how quickly you can do something. You should be measured by how thorough you can do something. So are there people out there that claim and then they possibly do rotator cuff surgery in 30 minutes? Yeah, maybe they're out there. I'm not really sure I want that person doing my, fixing my rotator cuff. If you can go in, thoroughly clean out my shoulder, evaluate my structures, make sure I have the best mobility and so forth, and you're in and out in 30 minutes, you're probably not doing the right thing. Not saying you're not, but you're probably not doing the right thing.
So
I don't know anybody that does that.
Yeah, you don't have a shot clock in your ER then, right?
Correct. So, but that being said,
they kind of do. I mean, like, you want to know your start time, and maybe you can go into this further, but surgeons want to know approximately how long, they're under anesthesia and how efficient they were in that day. They do. So there is a clock. There is a clock.
Oh, 100%. No, 100%. Well, that's the point. That's the other thing. I mean, if you have a single tendon tear and 4 hours later you're still going, that also is not ideal.
It's a problem. Yeah.
So, I mean, a standard single tendon tear in a relatively healthy shoulder that doesn't have a lot of bursitis, doesn't need a decompression, just you're going to go in, look, take down, some of the supporting ligamentous structures that are unnecessary, that are more beneficial to mobility in the shoulder, and you do a single double row repair, 3 anchors. That's an hour-long case, hour and maybe 45 minutes to an hour and a half, depending on the learning curve.
So when a patient when you're getting ready to do a shoulder procedure on a patient, you know, let's say that it's you think you're going to have to do a rotator cuff repair, but you know there's some uncertainty as to what you may come across. Are you telling the patient and the family ahead of time in the pre-op period, you know, of course, about all these alternatives? I know you are, but are you saying this could be a hour procedure? This could be 2 to 3 hours? Do you kind of give them some variance there, or some timeline ish?
You're usually pretty close. It's pretty rare that you go into the shoulder and completely find something that you didn't expect. You know, if you've been seeing the patient from start to finish, you know, good history and physical, and we talked about it last night at our meeting. History and physical is the key to diagnosis. You get a good history and physical, you know your problem is, you have the imaging that shows you that your diagnosis and your thought process is indeed accurate. You deem this patient a surgical candidate. There's not too many things that you go in there and it's like, oh, surprise. Now, for example, a partial thickness rotator cuff tear, right? So you have a patient that has a functional problem. You know, there's full thickness and partial thickness, and then without getting into the weeds of it, certain percentages of the tendon, depending on what side the tear is coming from, are more tolerated than others. So I have a patient, you know, a younger patient that has a slap tear that needs to have their labrum fixed and/or their biceps tenodesis, and they have a partial thickness tear. That patient knows that we're going to go in, we're going to fix your labrum, and we're going to look at your cuff. If I look at your cuff and your partial thickness tear, when I'm looking at it, actually is a more thorough or full thickness tear, I'm going to fix your rotator cuff at that time, right? But you know that ahead of time because you have a clinical exam that shows that. You have an MRI likely that shows that there's a problem. If you're going in there to do a labral repair and all of a sudden surprise you see a rotator cuff tear and you've not even had this conversation with the patient, you probably shouldn't be treating shoulders. You know, I mean that's just you know, that's just kind of the way it is. It's, you know, yes, we have that caveat, all indicated procedures, but it's indicated procedures based on what you think you're going to find or what you expect to find. And that all is done long before the patient even signs the consent. They know what to expect and what to see, what you likely are going to find.
You know, but there are some procedures where you know ahead of time that, like, hey, this could be something that's, if the tissue is good, that it's going to take me no time. Like, let's say you have a tear of the biceps tendon, you know, isn't sometimes a tear of that biceps tendon, you know, when you do have to repair it, it could be of a lower quality or it could be of a really good quality. And depending on that, you know, your timing, the how extensive could be a lot different.
Oh, absolutely. I mean, that's a great example. So that's a patient that you're going in for the purpose of, say, a rotator cuff repair. You know the patient has a rotator cuff tear, so you're going to go in, you're going to do the subacromial decompression. You know, the usual steps are when you put the scope and you go in the joint and you look around. So you go in, you look, take a quick tour around the joint. You know you're going to do a rotator cuff repair, so you do things like take down the medial ligament. You clean out the coracoid recess space. You basically open up the soft tissue so the shoulder joint is more mobile. I'm looking at the bicep at that point. Does the bicep look healthy? Does the bicep look unhealthy? If the bicep is frayed, erythematous, full of synovitis, I clean it off, and is it like this because of the hole in the rotator cuff, or is it like this because it's a separate pathology? If you determine that there's shredding and tearing and the biceps needs to be addressed, you cut the biceps tendon at that time. Depending on the patient population, body habit, and so forth, you either just cut it and leave it, tenotomy, or you anchor it down, tenodesis. And some people will do that in the shoulder. Some people will do that extra-articularly. Some people will do it below the pectoralis muscle through a separate incision. That's my preference, is sub-pec tenodesis. Then you go up top, decompress the shoulder, fix the rotator cuff, then address the bicep. But these are all things that doesn't add a significant amount of time to the procedure. A tenodesis is another 20, 30, maybe 40 minutes if you're going to do a sub-pec, depending, you know, on the case, on the procedure. But for the vast majority of time, there is an expectation to that. It's never really a surprise per se. It's just one of these, oh, okay, so this could be a problem. Let's fix it while we're here. But it's the other situation where, like, you don't go in to fix to do a simple supraspinatus tear and happen, oh, surprise, the the infraspinatus is completely torn off and retracted. That doesn't happen. I mean, yes, we miss things and we make mistakes, and the goal is to minimize those things. Maybe you don't appreciate something on your clinical exam. The MRI didn't quite pick it up, because that's very common. MRIs, while they do a great job, sometimes they're not always fully interpreted. They might overinterpret, they might underinterpret, and you might see something that you didn't quote unquote expect based on what the MRI said and so forth. But there was likely a hint at some point in the patient's history or the physical exam. It's not a surprise. That's kind of the whole idea. So the things do come up. Yeah, okay, maybe the subscap is a little more torn than you expected. I probably should put a stitch in this. It's minor things like that in the rare circumstances where all of a sudden you're adding hour and 2 hours to your case because of a pre-existing problem that you didn't notice on diagnosis or imaging. That's pretty rare.
Okay.
Great. Well, where do we find you, docs?
Yep. You can find me, Dr. Wiersbecki, or my partner, Dr. Ed Southard, at Florida Orthopedic Specialists, Port St. Lucie and in Stewart. Both of us go to both offices. The telephone number that'll connect you to either office is 335-4770, 335-4770. And we'll do bone talk again next week. We'll see you next week, Greg.
Sounds good.
Sounds
You
good.
have a good week, doctors. Bye-bye.
You too, sir.
You've been listening to Bone Talk right here on WPSL, Port St. Lucie. Talk of the Treasure Coast. Webcaster to the world on TuneIn.